Hi everyone, my name is Reese Garcia and I am the Research Advocacy Manager for Fight Colorectal Cancer. Thank you all for joining us for this webinar this afternoon or morning if you're on the West Coast. Today, Dr. Leonard Saltz will be discussing everything you need to know about oral chemotherapy and colorectal cancer. As always, thank you to the following webinar sponsors, Taiho Oncology, No Shave November, Genentech for making this webinar possible. A few housekeeping items before we begin. During the webinar, feel free to ask a question in the panel that says Q&A on the bottom of your screen. A recording of this webinar will be available on the FightCRC website at fightcrc.org. And if you have a Twitter account, please be sure to follow along using the hashtag CRCwebinar. FightCRC offers a wide variety of resources for those touched by colorectal cancer. And again, you can find all of these resources and materials on FightCRC's website. As a reminder, the information and services provided today are for general informational purposes only. The information and services are not intended to be substitutes for professional medical advice, diagnoses, or treatment. If you are ill or suspect that you're ill, please see a doctor immediately. In an emergency, please dial 911 or go to the nearest emergency room. FightCRC never recommends or endorses any specific physicians, products, or treatments for any condition. And with that, I would like to introduce today's speaker, Dr. Leonard Saltz. Dr. Saltz is a FightCRC Medical Advisory Board member and has been on the faculty of Memorial Sloan Kettering since 1989, and over the years has treated thousands of people with common as well as rare gastrointestinal cancers. He has particular expertise in managing cancers of the colon and rectum, as well as rare tumors of the digestive tract, such as carcinoid and pancreatic neuroendocrine tumors, as well as other digestive tract cancers such as liver, pancreas, stomach, and esophagus cancers. He also treats other neuroendocrine tumors as well. Much of his career has also been dedicated to developing new drug therapies and treatment strategies for colorectal cancer and has tapped the vast resources of Memorial Sloan Kettering, from various clinical departments to the Human Oncology and Pathogenesis Program, the Sloan Kettering Institute, and the Rockefeller University to create an integrated translational research program. He has served as chief of the Gastrointestinal Medical Oncology Service for 5 years. He is chair of the hospital's Pharmacy and Therapeutics Committee, as well as co-leader of the Colorectal Cancer Disease Management Team. He is also a professor of medicine at Weill Cornell Medical College. And with that, I would like to pass this over to Dr. Saltz to begin a wonderful presentation on oral chemotherapy and colorectal cancer. Dr. Saltz, it's all you.
Well, Reese, thank you very much. Hello, everybody. It's a pleasure to have a chance to speak with you. Reese, if you could move to the next slide, please. What I'm going to talk to you about today is just sort of a general overview of first, what is chemotherapy? Because I understand that for many of you, the journey with colorectal cancer is just beginning, and there's an awful lot of new information, new terminology that we need to help you get familiar and comfortable with. Then I'm going to discuss chemotherapy in terms of oral, meaning by mouth, versus intravenous, where we inject it into a vein. And how do they compare? I'm going to talk about what the common forms of oral chemotherapy as it relates to people with colorectal cancer and how people go about taking it, schedules and in what kind of settings and so on. The next slide, please. So let's start by defining chemotherapy. It's a big, scary word. Next to the word cancer, it may be the scariest word in the English language. And it is really just a fancy word for drugs. You've probably discovered that doctors love syllables. We like big words. I think it makes it sound important. We seem to add syllables for no particular reason. You notice no one takes medicine anymore. They take medication. Don't know why. And really no self-respecting doctor will use a one-syllable word when a five-syllable word will do. But I think one of the important things to do when we've got big, scary words is break them down and understand them. And all we're talking about when we say chemotherapy is drugs. And it's become standard that we tend to say chemotherapy means anti-cancer drugs. Technically, an antibiotic is chemotherapy for a bacterial infection, but we don't tend to use that word. So chemochemical therapy treatment equals drugs. Next slide, please. Now, there are different kinds of chemotherapy, and you'll see this terminology thrown around, and it's often misunderstood, and it's a little hard to sort out, especially because some of it gets wrapped up in marketing and so on. Cytotoxic chemotherapy. Cyto means cell, toxic, toxin, or poison, is the more standard chemotherapy. This is a drug designed to kill the cancer cell. And most chemotherapy would fall under that category. You'll hear the term biologic therapy or biotherapy. A biologic is simply a chemotherapy that's made in a living system. So a lot of the chemicals that we use to treat cancer are simple chemicals that we can make in the laboratory. A biologic is such a complex medical that only a living cell can make it. And so it's made in a culture of cells or in an animal or something of that nature. So it doesn't really refer to how it works, it refers to how it is made. And then there's the very misunderstood word targeted therapy. Everybody wants to believe that their therapy is targeted. Every marketer wants to believe that they're marketing a targeted therapy. Targeted therapy just implies that we know what target the drug is aimed at. In other words, what vulnerability in the cancer cell are we trying to hit with the drug? But it's not a new idea. Our oldest drugs, we understand the target just as well as our newer. The implicit term of targeted therapy it would have you believe that there's no side effects, that it only hits the tumor cell. And we wish that were the case. But unfortunately, that really is almost never the case because we don't have a drug that discriminates so effectively between cancer cells and normal cells. And so just understand as you look at the terminology that a, quote, targeted therapy is a relatively meaningless term. Next slide. Now, when we give chemotherapy, it has a purpose. Purpose varies. The best case scenario is when we're giving it with curative intent. Cure is a word that's very simple and straightforward. It's what we all want and wish we were aiming for, and sometimes we are. So when it's realistic to expect that the chemotherapy will cure the patient, we call it curative intent chemotherapy. Now, often a tumor is identified at an earlier stage, which means that it hasn't yet spread beyond the tumor itself or maybe the lymph nodes that are right around that tumor. We call that local regional cancer. And we may want to operate to take the tumor out. And then the doctor may talk to you about, now we want to give you chemotherapy. That's adjuvant chemotherapy, chemo given after surgery where we've taken everything that we know about out to try to mop up and kill any microscopic cancer cells that might still be involved. Sometimes we'll give that chemotherapy before a curative intent operation. In that case, neoadjuvant is the term that we use. So neoadjuvant, chemo given before an operation designed to cure, and adjuvant given after an operation designed to cure. In each case, these are also curative intent because what we're saying is the surgeon may have already cured the patient. We're adding the chemotherapy to improve the possibility, to increase the chances that we achieve the cure that we're hoping for. Now, all too often in colorectal and other types of cancer, the cancer may have spread to other sites of the body, spread to the liver, spread to the lung, spread to the bone, or to the lining of the abdomen called the peritoneum. That's called metastatic cancer. And unfortunately, we don't have chemotherapy that realistically can cure in most of those circumstances. So in that scenario, we call it palliative or non-curative chemotherapy. And it can still be a very, very substantial benefit to the patient. It may not get rid of the cancer, and realistically, it won't get completely rid of the cancer, but it can help shrink and control the cancer and potentially help the patient live longer and hopefully live better. Next slide, please. So how do we define if the chemotherapy is helpful? What does it mean if we say the chemotherapy works? Well, as I mentioned before, cure is a very simple word that means exactly what it sounds. Done with treatment, cancer never comes back, and the patient lives out his or her normal life without ever seeing that cancer again. Sometimes we can have that as a realistic goal, but with metastatic colorectal cancer, unless we can operate and take everything out, cure with chemotherapy is usually not a realistic goal. So we aim to improve survival, or overall survival as we call it. That's a measurement from the time that we start our treatment to how long the patient lives. And we always want to make that as long a time and as healthy a time as possible. So when we talk about chemotherapy, a question that we want to address, a question that you need to be thinking about, asking your doctor or your healthcare professional about, will this chemotherapy help improve my survival? Will it help me live longer? And what's a reasonable expectation of how much longer? Now, there are other terms that are a little less solid in terms of advantage, and it's important to understand them. We have a term in cancer called the progression-free survival, or PFS. This is misunderstood because it started out as a way for doctors to talk to doctors, but now it's become mainstream and used in discussing with patients as well, but the explanation is not always clear. Another term for it that I would prefer is the progression-free interval. It's the time from when we started therapy until the time the therapy is no longer working, or until the time that the patient dies, whichever comes first. And we don't really need the word survival in there to make it clear, because something may improve progression-free survival, but may not improve overall survival, may or may not help a person live longer. So in understanding what we're hoping to accomplish and what the chemotherapy can do for you, it's important to understand in discussions with your doctor what are the benefits that have been seen with these drugs before, and what can you realistically expect. Now, we talk about tumor responding to chemotherapy, and a response means that the tumor got smaller. And there are standard measures where we consider it a formal response, usually when it shrinks by roughly half of its volume. If the tumor doesn't really change, we call it stable disease. And the definition of stable disease may allow the tumor to grow just a little bit, because we say that that may be within the error of measurement. A term that I see creeping into the literature and into patient materials that are coming from companies is the disease control rate. This is mixing stable disease and response together. I'm not really fond of it because I think it confuses people as to whether they can realistically expect the tumor to shrink or not. A response rate is the percentage, the rate at which we can expect the tumor to shrink to a meaningful degree. So if we treat 100 people and 50 of them have the tumor shrink by half, we'd call that a 50% response rate. Disease control rate is the percentage where the tumor doesn't grow over a period of time, and it's important to ask how long that period of time is. Sometimes it's just a few months. So what we're really looking for, ideally we want cure. When that's not possible, we want overall survival improvement, and response or shrinking of the tumor can be very important in terms of relieving tumor-related symptoms and as an indicator that the drug is working and moving us in the direction of these other benefits. Next slide, please. Now, we often hear the term significant response rate, significant survival benefit, significant PFS benefit. And unfortunately, this has become the source of a lot of unfair confusion out there. And so it's important to realize that significant is not the same as substantial. A significant improvement, whether it's improvement in cure rate, response rate, survival rate, whatever, means that statistically we can prove that whatever difference we're seeing is likely due to the chemo and not just a random event or due to chance. You can have a significant survival benefit that may be limited to a very short period of time. So when we talk about the survival benefit of the drug, a substantial survival benefit would be something that would be a very long amount of extra time. And again, it's important to be open and asking these questions. When someone says there's significant survival benefit, it's fair and relevant to ask, well, how substantial is that significant survival benefit? Significant is just telling you it's real. It's not a it's not a false reading of the study, but it's not telling you how much benefit is there. Next slide, please. So a couple of things to think about in terms of chemotherapy. The reason that chemotherapy is a scary word is that we're all worried about the side effects of chemotherapy, or what we call the toxicity of chemotherapy. And so as you deal with your cancer and your drugs and their side effects, it's really important to remember chemotherapy is a fancy word for drugs. There are many different drugs that are used in cancer chemotherapy, and different drugs may have different side effects. Different people may get different side effects from the same drug. So for any two of the people listening here, if we give each of you the same drug, one of you may have an easy time with that drug and one of you may have a hard time with that drug. Or one of you may have one side effect and one of you may have another, and a third may have both and a fourth may have neither. So everybody's experience is different, and it's really important as people want to help you and they hear that you have cancer. All too often they will relate a story to you about either their experience or somebody else's experience with chemo. Whether that's a good experience or a bad experience, be careful not to assume it means anything for you. And remember that different people on the same drug may get the same or different degree of side effects. Let's say that a drug causes diarrhea. One person may get no diarrhea. One person may get a little bit of diarrhea that's just a minor problem. And another person may get diarrhea so severe that it could land them in the hospital needing intravenous fluid. So all of these are possible. And until we get a chance to see how a particular drug or combination of drugs works for you, we don't really know what the experience is going to be. Doctors don't like to make people sick. Doctors like to make people better. And so if we find that the side effects are too severe, we work to control that. We start with a dose, usually based on your height and weight, and then we modify as we see how we're doing. That first dose that's based on your height and weight will be right for the majority of patients, but for some, it's going to be an overshoot and we're going to have to pull back until we make the side effects acceptable for you. And that's a really important point. When people talk about, is a side effect tolerable or not, you, the patient, have to answer that question. If you have a side effect, it doesn't physically hurt your doctor one bit. You're the one that has to decide if it's a problem. Now, you need to be talking with your doctor and describing it so that he or she can make adjustments for safety purposes. It may be that you have a side effect that doesn't bother you much now, but the doctor could anticipate how this would become dangerous down the road and want to make an adjustment. So two-way communication with your doctor is really important. Next slide, please. And again, to emphasize, remember, another person's experience with chemotherapy has little or nothing to do with what your experience will be. Next slide, please. Now, I was specifically asked to talk about oral chemotherapy, and I stayed away from copying the title, Everything You Want to Know, because there's always going to be questions. I'm going to try to anticipate the questions that most of my patients ask, and you'll have others, and I hope at the end you'll bring those questions up so that we can try to address them. One of the things that I always try to emphasize to my patients, if you remember a quarter of what we're talking about at any given time, a meeting with your doctor or a lecture like this, you're way ahead of the game. The only thing you really have to remember is it's always okay to ask questions. And you can't assume that we as docs can read people's minds and know what's on their mind. So there's no such thing as a foolish question. It doesn't matter if we might have covered it before. If it's on your mind, you need to let your doctor know about it so that we can try to address it. Now, talking about oral chemotherapy, on one hand, you might say, well, hey, it's very straightforward, right? Pills are better than getting needles stuck in my arm. There was even one silly study that was done a number of years ago where somebody interviewed patients and came to the conclusion that people would rather stay home and take pills than go to a clinic and get a needle stuck in their arm and deal with the issues of all of the having to deal with that. So the one advantage is obvious. You can take it at home. Many oral chemotherapies are such that you don't really need to see the doctor that often, and so it can be fewer clinic visits. And I don't know anyone that likes needles, so anything that avoids needles is probably a good thing. And for many of our chemotherapies that are given intravenously or injected directly into the vein, we need a port of some sort, a metaport or an access device, usually that goes under the skin, under the collarbone, where we put the needle in so that we don't have to keep using veins and needle sticks in the arm. Now, what are the downsides? Why wouldn't everybody want every drug orally? Well, oral chemotherapy puts a lot of responsibility on the patient. And so as a doctor, when I'm thinking about whether oral chemotherapy is a reasonable option to offer, I have to think about, can this person handle the responsibility? Are they going to be organized enough to take their medicine on a complicated schedule at the right time and not take the medicine if they're starting to get side effects? Maybe take it if they're having very minor side effects, but hold it if they're getting major side effects. Will they remember to take it twice a day? Will they remember which days to take it, which days not to take it? That's a lot of responsibility to put on a patient. When I give somebody an intravenous medicine, I take all that responsibility. I know exactly how much drug the person got, exactly when they got it, and then on the basis of follow-up conversations, we can decide if we're happy with that dose or not. With oral chemotherapy, I send somebody home with a big bottle of pills and some written directions, and again, we're counting on that patient and or their caregivers to get it right, but there's opportunity for mistakes and omissions and errors, so we have to be careful. Another issue is you gotta be able to eat. You can't take medicine by mouth if you can't take food by mouth. And so if somebody is feeling queasy, is feeling nauseous, just doesn't have an appetite, swallowing pills, and sometimes they're large pills and lots of pills, may be a problem for them. And taking it by injection might be easier than having to deal with the pills. Now, I have a number of patients who just say, I can't swallow pills. I certainly can't swallow big pills. If a person tells me that, that's not going to change, okay? That's something they've dealt with all their life, and we have to respect that and say, okay, we need to move on and discuss something that doesn't require the person to swallow pills. Very, very, very few chemotherapies can be given in liquid form. Many of them are in pills that can't be cut or broken because of exposure and time release and various other issues. So being able to swallow pills is essentially a factor necessary in oral chemotherapy. And of course, if somebody has cancer that's interfering with their ability to eat, interfering with their gut function, that's going to be a problem for oral chemo. The last one that is sometimes a problem is the issue of the copay, or the so-called financial toxicity. Chemotherapy in general has unfortunately gotten very expensive. Some of the oral medications we talk about cost a few $1,000s a month, and some of them cost between $15,000 and $20,000 a month. Obviously, no one's going to be paying for that kind of thing out of pocket. Insurance is going to pay all of it in some cases, but depending on your insurance, you may have a copay or a co-insurance payment that you have to make. And this can be more of an issue usually with oral medications, which are often on your pharmacy benefit plan, than on intravenous chemotherapies, which are covered more under your hospital and medical care plan. And there tends to be less copay issues there. These are questions that need to be thought about and sorted out and talked with your doctor before you make final decisions on whether you're going to do chemotherapy by mouth or chemotherapy by vein. And I think it's super important that, like with any other aspect of your care, that you feel comfortable bringing up your concerns with your doctor. It's expected that if you have problems with your bowel function, if you have problems with your urine function, if you have sexual problems, if you have other personal issues, you got to bring it up with your doctor. And no one's going to be uncomfortable about that from the doctor's perspective. Similarly, if you have financial concerns, how could we not say, well, that one's off the table? that's got to be something you're comfortable talking with the doctor as well, because if it's going to create a financial problem for you, A, that's going to put an extra stress on you that you don't need because you got plenty of it if you're dealing with cancer. And B, it could interfere with you getting the treatment that you need. And if you don't get the treatment and take it, it can't work. Next slide, please. So who is oral chemotherapy a good choice for? Who should be thinking about it? Well, along the lines of what I mentioned, you need a motivated patient. You need someone who says, I want chemotherapy. I'm taking control of my disease, and I am going to take responsibility for getting it down and getting it right, and not overdosing, not underdosing, but doing it the way it's prescribed. So sometimes, especially with more frail or elderly people, there's a lot of sort of back and forth equivocation as to whether they really want treatment or not. Someone whose family is really the driving force on chemo, that person's not going to do well with oral chemotherapy, and it's going to set up conflict between the patient and the caregiver. So again, a motivated patient, a patient who's going to take control of his or her treatment and bear that responsibility, is a good choice for oral chemotherapy. They have to be willing and able to keep track of what they've taken and maintain the schedule. You got to have a way of knowing, did I take it today? Gee, it's 11 o'clock. I meant to take it right after breakfast. Did I do that? Or was that yesterday? Some way where you can be organized, keep a written record, trust yourself to do it. Sometimes you get chemotherapy that is taken for a few weeks and then a week off. Sometimes it's chemotherapy just on weekdays and not weekends. These can be complicated, and you need someone that can follow these instructions and remember them. Yes, caregivers can be helpful, but the patient's got to drive the bus here. You need someone who can assess their own side effects and communicate with their provider, so that if somebody has mild symptoms, we may ask you to tell us about that so we can decide if we want to make some mid-course corrections. But if somebody's got more substantial symptoms, really important that they stop the drug and call us so that we can decide when and if to restart and what other interventions we should make. And if somebody is not having any side effects at all, communicating that so we can discuss, are we underdoing it with the drug? Is there room to go up a little bit larger? And as I mentioned, it's got to be somebody who can eat normally and swallow pretty good sized pills without much concern. If somebody expresses any reservation about the ability to take pills, the likelihood they're going to be able to do it well with oral chemotherapy is small. Next slide. So now let's talk about chemotherapy specifically for people with colorectal cancer, because as I mentioned, chemotherapy is just a word for drugs. Even if we make it more specific and say drugs for cancer, different drugs are used for different cancers. So if you've heard about the experience of somebody that had breast cancer or lung cancer or lymphoma or prostate cancer, very, very unlikely that they were going to be exposed to the same group of drugs as somebody with colorectal cancer. Next slide, please. So here's a list of the intravenous chemotherapy drugs that we use for colorectal cancer, and I use the abbreviation CRC for colorectal cancer pretty frequently. And what I've shown you here for the most part are what we call the generic names. Drugs all have a generic name and a brand name. The older drugs, the brand names are virtually forgotten because we use it all as generics. The newer drugs often are referred to by their brand name, and I'll mention those a little bit later in this talk just to avoid confusion. 5-fluorouracil is the oldest, most common. Leucovorin is just a vitamin. It doesn't do anything by itself, but makes 5-FU a little bit more potent. And then you can see these other drugs, irinotecan, oxaliplatin, bevacizumab, aflibercept, ramucirumab, cetuximab, panitumumab. You see how much we love syllables? I had to practice all of those in a mirror. For all of them, we tend to have shorthands and abbreviations. Next slide, please. And so you'll often hear about the combination regimens for chemotherapy. A regimen is a cocktail. It's basically pulling the drugs together. And the most common regimens that we talk about in colon cancer are called FOLFOX and FOLFIRI, And these are acronyms. They're using abbreviations for some of the drugs that I just showed you on the previous slide. So if you look at the bottom of the slide, you'll see where I have abbreviations listed out there. FOL is folinic acid, which we often call leucovorin. It's very similar to folic acid, the vitamin. It's really folic acid with hydrogen atoms on it. And as I say, it does absolutely nothing by itself. But when we give fluorouracil or 5-FU with leucovorin, leucovorin makes it a little bit more potent. So the FOLF in FOLFOX and FOLFIRI, or the combination FOLFIRINOX or FOLFOXIRI, that's folinic acid and fluorouracil. The IRI in all of these acronyms is irinotecan, and the OX in all of these acronyms is oxaliplatin. All of these involve giving the drug fluorouracil as a 48-hour infusion, and all of them are given every other week. So these are all regimens that people get going to the doctor's office for a few hours once every 14 days, and going home with a pump hooked up to their Metaport that gives intravenous chemotherapy for 2 days for 48 hours. Next slide, please. These regimens, FOLFOX, FOLFIRI, and FOLFIRINOX, and FOLFOXIRI, they're often given with a biologic, which I've listed now at the bottom of this particular slide. And I've thrown in some of the brand names to avoid confusion. These are drugs that are rarely given by themselves, more commonly given with some of the chemotherapy. These are intravenous as well. And so you may have FOLFOX plus bevacizumab, or FOLFIRI plus panitumumab, or FOLFIRINOX plus cetuximab. Again, combinations that in various different situations may be appropriate and your doctor would discuss, because of course, with each drug you add to the combination, you bring along its own portfolio of side effects and you add those side effects together. So more drugs you give, perhaps the more aggressive in terms of hitting the tumor, but perhaps more downside in terms of side effects. And remember that aggressive is not always a good word. Often patients will come to me and say, I want to be aggressive about this. You know, an open field charge at a machine gun nest is very aggressive, but it's not really very productive, and it doesn't get you where you want to go. And when we think about chemotherapy for patients with colorectal cancer, a bit of a chess game. We've got to think, what's our first move? What's our next move going to be? What's our move after that? How are we going to respond if the tumor behaves one way? How are we going to respond if the tumor behaves another way? And firing all our weapons up front is not always the smartest way to approach it. So you may find that under some circumstances, your doctor is going to recommend a combination of therapies, and under other circumstances, just 1 or 2 drugs. Next slide, please. Now, in terms of oral chemotherapy, these are the 3 drugs that have regulatory approval, FDA approval in the United States for treatment with colorectal cancer by mouth. And it's this first one, capecitabine, that I'm going to talk about the most. There's also more as kind of a backup regimen when other drugs have not worked as well as we wished. Regorafenib or TAS-102, they go by the trade name Stivarga or Lonsurf, and they're only available as these trade drugs. Capecitabine is a drug that came on the market in 1998 under the brand name Xeloda, and you still see both terminologies used, but in most cases in medical care, at least at our hospital, whenever a generic drug is available, we use it because realistically it's the same chemical, but it's less expensive. Next slide, please. Now, I mentioned in the intravenous drugs, the drug 5-fluorouracil, often referred to as 5-FU. And I've shown you a little chicken wire diagram here of what this looks like for those of you that remember high school chemistry and have a sense of what we're talking about here. It's a ring of 6 atoms and then a fluorine hanging off it. That's the 5-fluorouracil. Now, this drug is a source of tremendous embarrassment to people like myself who have spent a lot of time and a lot of effort and a lot of thought trying to come up with something better. Because this drug was patented in August of 1957, and it's arguably still the most important drug that we have in treating colorectal cancer. And you can argue that virtually every drug that came along since was a bit of a failure, because its goal was to defeat 5-FU and replace it as our frontline standard. And instead, it wound up in kind of a if you can't beat them, join them phenomenon, where it's sort of added on to regimens with other drugs. Now, 5-FU could, in theory, be taken by mouth. The problem is, can I have the next slide, please? When you take 5-FU by mouth, it absorbs through the small intestines, and just like your breakfast or lunch would absorb through the small intestines. And just like your breakfast or lunch, when it absorbs in, the first place that it goes, because of the way blood flows, is to the liver. And in the liver is an enzyme that breaks down 5-FU. It goes by the initials DPD. And DPD levels vary tremendously from person to person. So if you and I each took 500 milligrams of 5-FU by mouth, we would have very different blood levels, because one of us would metabolize it and break it down faster than the other. So it would be very, very hard to figure out what the right and safe dose is. Next slide, please. So this is where capecitabine comes along. This is the molecule, and the reason I'm showing you this, go to the next slide and you'll see, watch closely. Here we go back to 5-FU. We just take away all that stuff, next slide, and here you see we're back to capecitabine. By adding these two sections on, two very clever Japanese chemists came up with this in the 1990s. And this is sort of a chemical cap on 5-FU, so that it can absorb orally without breaking down. And so what happens is, this is the chemical that you take in the pill. It doesn't irritate the stomach because it is inactive because of all these little chains that have been added to it. It absorbs in the small intestine, and it absorbs more effectively when you're absorbing a meal. And so we tell people, take your morning dose right after breakfast and take your evening dose right after dinner, not because you need the food to protect your stomach, you don't, but because as you're absorbing that food, you'll absorb the drug more efficiently. Then in the body, next slide, please. Last little bit of chemistry. I apologize. This is a little more complicated than you may want, but I think it helps you understand. What happens is a series of enzymes break the drug down. And at the end, if you just follow the arrows in a little Z pattern across this slide here, you'll see we wind up with our old friend 5-FU, our 63-year-old drug that we still don't have anything better than. And so capecitabine is an elegant way of allowing this intravenous drug to be given orally. It is not a different drug than 5-FU. It is a prodrug that is activated in the body to become 5-FU. Next slide, please. So here we are back with 5-FU. This is the active agent. When you take capecitabine by mouth, this is what your body breaks it down into, and now you have 5-FU in your bloodstream that attacks your tumor. Next slide, please. So how about looking at what we know and what we think we know about oral chemotherapy? Oral does not mean less aggressive or less effective. There's this general sense, well, the real chemo must be the IV stuff, and the oral, well, maybe that's sort of chemo light. Not the case. And for that reason, oral does not mean either fewer or milder side effects. It might mean different side effects, but it would be wrong to think that oral chemotherapy is either less prone to causing side effects or less toxic or more prone, simply different. It doesn't necessarily mean it's easier, because you may get those side effects and it's still your responsibility to take this medicine. It's neither better or worse, okay? It's not that we can say IV is better than oral or oral is better than IV, either by effectiveness, by side effect, or in general, whether it's better for patients. It's going to be better as a choice for some patients and not better for others. So it's not for everyone. It's a good choice for some. It's an option to be thought about. And thinking will make the answer yes or no, depending on who you are and what your circumstances are. Next slide, please. Now, capecitabine is a drug that has a somewhat complicated treatment schedule, and this is part of that responsibility that we ask patients to make. It's based on body surface area. Body surface area is calculated by your doctor based on measuring your height and weight. So that basically how much of you is there, and then, so a very small person will get less drug than a very big person. It comes in 2 tablet sizes, but honestly, I've never prescribed anything other than the 1 large tablet, 500 milligram size. And people vary based on their size as to how many tablets, but it varies usually between 3 to 4 tablets per dose. So we'll tell somebody take, depending on how it calculates out, 3 pills after breakfast and 3 pills after dinner. Somebody else may be 4 pills after breakfast and 3 pills after dinner. This is what we calculate out and write into your prescription. And the way the drug was developed is dosed twice a day for 2 weeks in a row, and then a 1-week break. And as I mentioned before, we tell people to take it right after a meal so that you get more efficient absorption out of your gut and into your bloodstream where we want it. Next slide, please. Common side effects of capecitabine. The first, second, third, and fourth thing that we worry about, the most common side effect is what we call hand-foot syndrome. Now that's the short English common sense version for it. As I mentioned, doctors love syllables. So we can call this palmar plantar erythrodysesthesia, which I was embarrassed to even write on the slide. So that's why we call it hand-foot syndrome. The unusual side effect that we don't quite understand, but basically it is dryness, redness, and sometimes peeling and cracking of the skin on the palms of the hand and the soles of the feet. And the most effective thing we found for treating this is hand lotion. Basically any non-fragranced white hand lotion that you buy in the supermarket or drugstore. And we tell you to get a lotion you like, carry a tube in your pocket, and use it 4 or 5 times a day on both your hands and feet. And moisturizing in that way tends to reduce the side effect and help people cope with it. If that doesn't adequately control it, then we have to modify the dose and have you take a few less pills. Diarrhea is the side effect of 5-FU, and it can be a side effect of capecitabine. It's less common than the hand-foot syndrome. And mouth sores, irritation of the membranes in the mouth can happen from either intravenous 5-FU or capecitabine. But the overwhelming majority of people that have side effects from capecitabine, the hand-foot syndrome is going to be the biggest problem. Now, when you talk to people about chemotherapy, usually the first thing they're worried about is nausea and vomiting. 2 words about that. Firstly, very unusual for that to be a side effect with either the IV 5-FU or the oral capecitabine. And if it is, we have very effective anti-nausea medicines. So for most people, we really can control that problem. So I don't think of that as a problem with this chemotherapy as opposed to some other chemotherapy. The other thing is some chemotherapies can lower your white blood cell count. And white blood cells are your first line of defense against infection. When you give 5-FU intravenously, it is more likely that you can lower the white blood cell count. Capecitabine very rarely lowers the white blood cell count. And so in the absence of somebody with a fever, we don't really need to measure the white count on a regular basis. And so I can treat somebody with capecitabine at home. And this is very relevant in this era of telemedicine, because now we're basically trying to minimize people exposure to COVID-19, and this allows them to stay home and be treated. Next slide, please. The capecitabine can be given by itself, or it can be mixed with some of the other intravenous agents that I've mentioned, now you're getting some IV and some oral. And these are regimens that your doctor would talk to you about if appropriate. Next slide, please. Other agents, I mentioned regorafenib or Stivarga, TAS 102, or Lonsurf. These are oral agents. We tend to use these as a backup if other agents have stopped working. I wish they had more anti-tumor activity than we've seen in the studies. Each was approved after other therapies stopped working in patients who were still feeling well and eating well. And they added a few months survival benefit at most. It was not, on average, a substantial improvement. So these drugs have their side effects, modest activity, something we talk about usually when we've played out our hand on other options. Next slide, please. So in conclusion, chemotherapy, it's simply another word for drugs. Some drugs are given intravenously and some by mouth. Any and all drugs can have side effects, and oral is neither better nor worse than IV. It's simply different. Thank you very much for your attention. I hope this conversation has been helpful to you, and I'd be happy to take questions.
Awesome. Well, thank you so much, Dr. Saltz. That was extremely informative, and I have to agree with your observation that all these terms tend to have many syllables. So again, thank you for this really insightful presentation. So we do have about 10 minutes for questions and answers, and we had a few come in and prior to the webinar as well as during. So the first question that I would like to bring up is, are there any major drug interactions or food interactions that patients should be aware of, specifically as it relates to capecitabine, but also with maybe any of the other orals?
So we don't specifically advise people that they have to restrict their diet tremendously. We do have evidence that when people are eating well, in other words, they're not fighting to get calories in, that diets that are higher in vegetables and seafood and lower in red meat and animal fat and higher in whole grain and lower in refined grain and sugar may help the body fight cancer, and so we encourage that kind of diet. But in terms of specific foods that must be avoided on this drug or specific foods you must eat, not particularly.
Great, thank you. And then, you know, you mentioned several times that the responsibility is really on the patient when taking oral chemotherapy. So what do you recommend patients do if they miss a dose? Or do you have any recommendations for patients to set reminders or stay on track when taking oral chemotherapy at home?
So when we have somebody on oral chemo, we discuss with them what would work for them in terms of keeping track. Would having a calendar and a checkoff box be a good idea? Would having some kind of reminder in their phone, some kind of electronic pill box? There are a number of different strategies, and talking with your providers about what would work for you to help you stay organized and remember is important. If you miss a dose, realistically, probably not a huge deal, but if you think about it, you're taking 28 doses in a 21-day period. If you imagine someone trying to do a study of 28 versus 27 doses, the likelihood that that would really make a difference is vanishingly small. So we don't want to miss doses on a regular basis. We don't want to panic if it happens.
Sure, and then—
And when in doubt, call your doctor and ask for guidance.
It's a great recommendation. And then as a follow-up to that, have you noticed any major concerns presented by patients during COVID-19 in terms of being able to keep up with their oral chemotherapy or being able to get prescriptions mailed to them? How has your experience been with that?
So actually COVID-19, I think, has shifted us to try to do single agent oral whenever possible. Right now where I am in New York, the COVID prevalence is very low, but it was terrible at the end of March and April and May. And so we sort of were in the forefront of trying to figure out how to minimize our patients' exposures and minimize their visits to us. So now, unfortunately, other parts of the country are experiencing big surges in this disease, and it becomes even more important to protect patients from unnecessary travel and exposures. So oral chemotherapy does have that potential advantage, and pharmacies have tended to be extremely helpful in providing the medications through mail order.
That's great. And I would tend to agree with that. I think it's very helpful that, patients don't necessarily have to go in and be in person for this treatment. I know that we just had virtual ASCO. It's been kind of ongoing between June and August. Were there any trials or research presented that you think are worth highlighting to our community, investigating new oral chemo drugs, whether, in combination or whatnot?
Well, I think one of the most important changes in my thinking about treating people with colorectal cancer comes from the IDEA study, IDEA, which was a very large study in people after they had an operation to remove stage 3 cancer and some stage 2 cancer. These are earlier stage cancers, not metastatic, and we typically give chemotherapy for a period of time afterwards. And what was found is that the combination of intravenous oxaliplatin and oral capecitabine was virtually as good if we gave it for 3 months as if we gave it for 6. And that's we were traditionally treating people for half a year, and that was giving people more drug and more side effects than I think was really necessary. And so now our evidence suggests that with the CAPE-OX regimen, the capecitabine oxaliplatin, for the overwhelming majority of people who need an oxaliplatin-containing regimen after surgery, that 3 months is enough. So that's really important because we want to give everybody the best chance to be cured, but we don't want to give people long-term side effects whenever we can avoid it.
Absolutely. Well, thank you for that. And I know you touched on this a bit, but are there any other factors that doctors typically consider when deciding to prescribe an oral or intravenous chemotherapy? So anything about prior treatment or age or any other type of factors that go into that consideration?
So you mentioned age, and that does potentially make capecitabine a little more complicated because there are some metabolites there that are cleared by the kidneys, and as we get older, the kidneys don't clear quite as efficiently. So over the age of 65 or 70, we have to think about modifying the dose a bit. That would be one factor. There are people 85 years old that are mentally sharp as a tack, and there are people younger than that are just not as sharp as they used to be. And I think a doctor has to take that person's sort of mental function into account in terms of whether the patient is going to be able to handle and control the oral medication.
Great, thank you. Well, it looks like that is all the questions we have. If anybody else on the line has questions or is watching this at a later date and thinks of a question for Dr. Saltz, you can feel free to email us at webinar@fightcrc.org, and we'll be happy to pass those questions along to Dr. Saltz. And with that, we would like to say thank you to everyone who joined us today, everyone who's listening at a later date, as well as a big thank you to Dr. Saltz for leading this webinar today. I know we're all living in a very hectic and busy time, so we appreciate all of you spending an hour of your day with us. And we hope that you have a good rest of the week. So thank you, Dr. Saltz, and thank you to everyone that attended.
Take care, everybody.
Thank you.